I can see participants are just ticking in, but just in the meanwhile, we'll wait a minute and then I'll ask our speakers to introduce themselves in turn. As Andrew, would you be able to start and then we'll move through our speakers?
Yes, certainly. So, well, good afternoon, good morning, depending on where you are in the world. My name is Andrew Davis. I'm Digital Health Lead at ABHI, which is the Association of British Health Tech Industries. We're a trade association for medical device, diagnostic and digital health companies.
Great. Richard, would you like to follow on from Andrew?
Thanks, Sharon, and thanks for the invitation to be with you. I'm a colleague of Andrew at the Association of British Health Tech Industries. I look after the policy and communications. I've also got some NHS credentials in that I'm on the board of directors of the Royal Orthopaedic Hospital in Birmingham. So I can give you a bit of frontline feedback from the service as it is at the moment.
Thank you. And Sophie, would you like to?
Of course, it's a pleasure to be here, so thanks for the invitation, Sharon. My name is Sophie Gazal. I am the Global Lead for Digital Health Solutions and Partnerships at Merck Sharp & Dohme, MSD. I've been involved in global digital transformations with life sciences company for a few years now, both in my current role and previously as a management consultant. And more broadly, I also worked in market access and policy, so working with trade associations here in the UK on medicines policy.
Oh, great. I'm very pleased you can join us. And finally, but last but not least, Toby.
Thanks, Sharon. Hi, everyone. My name is Toby. I'm the CEO and founder of Entia. I'm a company that's redefining how people manage life-changing health conditions such as cancer by enabling treatment and management to take place in the home. We predominantly work on the sort of digital solutions and blood testing that allows remote healthcare teams to make treatment decisions, working extensively with big pharma to facilitate treatment adoption and sort of usage, and also with world-leading healthcare trusts on optimization of their services as well.
Yeah, so excellent and very exciting things that you're doing at Entia. We have a number of topics that we are discussing today. To start, though, a little bit of a scene set around COVID-19, but particularly for the medtech industry and our experiences and learnings, particularly in relation to faster adoption of technologies and the willingness both of clinicians and patients to adopt new technologies. Clearly, this has had a big impact, not only on medtech and digital health, but it has had a profound impact for medical technologies. And I actually thought, Richard, if you could kick us off possibly by describing some of your frontline hospital experience, what that's felt like in hospitals. You've all read the reports of a huge take-up in telemedicine, but an adoption of different types of tools. And if you could start us off, that would be brilliant.
Yeah, thanks, Sharon. Yeah, it's been interesting, hasn't it? It's I think there's a bit of a truism developed already that things that took the NHS, it's famously gargantuan organisation, or with the fourth or fifth biggest employer on the planet, years to do things is happening in months, if not weeks. Things that took months to do are happening in hours, if not days. So yeah, there's been, we saw from the outset, I think the role that technology has had to play in supporting us through the pandemic. Someone made a really interesting comment, I think, at the very start of this, that what COVID has done, it's brought experts and industry back into fashion in the UK. Industry were the bad guys throughout the Brexit referendum period. Immediately after, we were doom and gloom merchants, and experts were were also being dismissed left, right, and centre as well, again for being doom and gloom merchants. But I think what we've understood is that people now are beginning to trust expert. I think it's absolutely fantastic that we've got frontline hardcore scientists on our TV screens most evening. We're back off the daily briefings at the moment, but they were there on our TV screens. So people are beginning to trust experts to keep us all safe, and also people beginning to trust industry industry to make some of the technologies they need to facilitate that. So there was a big focus, for example, on ventilators at the start of this. That's morphed into PPE and testing as well. So people begin to really understand the benefits that technology can play. From an operational perspective in the NHS, I think the service has massively picked up the use of technology. I think it's fair to say the UK was sometimes regarded as a fairly late and slow adopter of technologies, and certainly in terms of digital, I don't think we ever made particularly good use of the telephone in doing, for example, outpatients. I remember doing some work probably 20 years ago about a thing called closing the shed, which was where we have this fatally ridiculous notion where we have these enormous sheds tacked onto the side of our big acute hospitals called outpatients departments. Well, no one can park when they turn up. Most people don't have to be there. So my own trust is a small trust, but at the moment we're doing somewhere between 500 and 600 outpatient appointments per week. Only about 60 or 70 of those are now face-to-face. And this is orthopedics. This is a specialty where probably more than others, you want to examine people, check people's mobility. But we found that we've really kind of embraced that technology, and our clinicians are embracing it as well. And we're hearing this a lot from the service. Well, this is a really neat way to do things. Why haven't we always done this? So I think the one thing this is, if anything good can come out of this, is that recognition that we need to get on and adopt technology, and a lot of the barriers that were in place before are now being seen largely as excuses. Well, we can't do this, there's governance issues, we can't share information. We had a really interesting conversation with the Royal College of Physicians a couple of weeks ago when the guy who's the lead from the college was wanting to do remote clinics in his cardiology practice. And somebody said, well, we can't use Zoom for meetings because it gives identifiable patient data. And the guy said, well, of course it does. That's what we need to be able to run a clinic. But what might have taken a sort of year to get around that, the information governance lead for the trusted, look, I will accept personal responsibility for this. So I think it's been a real catalyst to do things we've been trying to do a long time. And I think people are, both clinicians, but also patients, are now beginning to realise the benefits.
So Richard, do you think from that it's really cultural, that we could have done this all quicker and it's just been an example of what we could do, or is it?
Yeah, it's hard to understand why we have not been running outpatient clinics, only bringing those people onto hospital sites that actually need to be there. It's kind of hard to think, well, why haven't we done that before? And I think a lot of us on the call probably scratching our heads, well, why hasn't this been done before? And I know Toby will talk about some of his fantastic technologies allowing patients to be treated at a hospital. Well, the 5-year forward view, which was 7-8 years ago now, talked about enhancing care enhancing health in care homes, which has been really sort of crucial to the pandemic, and it will be crucial in managing the pandemic going forward.
Well, that seems like an excellent segue to Toby to talk about your technologies and how they've been adopted, how they've been used through COVID.
Yeah, no, I think to sort of talk about our technologies, you have to start with sort of what's been happening within healthcare systems around the world. And I think it's only just coming to light some of the sort of the really harsh realities that COVID had brought upon people and healthcare services dealing with chronic health conditions. I think the press has been very heavily focused around sort of, COVID itself. But behind the scenes, I mean, we've had oncologists, the people dealing with cancer, and like nurses, doctors having to actually select which patients continue treatment. And as a result of that, we're now only just beginning to hear about press releases coming out saying that somewhere between 7,000 and 35,000 people just in the UK alone are going to die of cancer. And that is all because of the fact that there just hasn't been the resource and the ability to actually manage these patients. They're at high risk, they've been kept in isolation, and on top of that, there just hasn't been the ability to bring them all in. And so really, I think the change that we personally saw as a company, I think, was very much in the fact that there wasn't a choice. I mean, if you wanted to save your patient, if you wanted to work with them, you had to innovate. And that's a very interesting dynamic that healthcare institutes suddenly found themselves as the ones having to find solutions for the problems they're encountering in very short space of time. And in many ways, I mean, I guess the sad part of all of it was that it moved so quickly that even for us as a small company, as innovative as we are and sort of how great our supply chains are, we just couldn't actually address the size of the issue that we were encountering. I mean, we had people contacting us from the US, Italy, Spain, all asking for solutions to help with their patients, but we sort of, had to prioritize those that we could work with. And that was largely down to the fact that, I think a very positive thing is that certainly in the UK, the government has been very effective to put in place centralized pots of funding to help, support innovation. And we've been able to access 4 sets of funding now that have allowed us to actively go out and find the NHS trusts with the highest need, and to actually offer our solutions, home monitoring solutions that allow them to suddenly understand how their patients are doing without having to bring them into hospital. And we had some patients who had gone 6 months without having any checkup when they're meant to be on monthly checkups. So there has been a wonderful upside to this, but unfortunately in the grand scheme of things, the onset was so quick that we haven't really been able to see the full adoption that we'd like to have seen.
And I guess this is going to continue for some time. I mean, it looks like it'll be with us for the foreseeable.
Yeah, I think Richard yesterday, when we were chatting, mentioned that we're looking at probably a long-term 20% reduction in capacity issues, because we are going to be operating healthcare services that constantly having to deal with some degree of COVID. It's going to be present. And I mean, cancer waiting times before we went into COVID were sort of sat at, I think 22% of patients weren't receiving treatment within 6 weeks of diagnosis. And that's just going to have gone through the roof. And you add an extra 20% of resource limitation, then there is a long-term need, I think, for adoption in this space.
And I think for the benefit of our audience, that's just because of the delays that are required, changing flows in hospitals. That's what you're referring to.
Yes.
Sophie, really good to hear your perspectives too. I mean, you come from I think we've got a great range of perspectives here. What are your thoughts of what we've learned so far?
Yes, and maybe let me open up by saying that my comments represent my own views and not those of my company. You're a lawyer, so I have to say that. But Sharon, I think the fundamental change in that the pandemic brought is that it shifted the conversation from the technology itself, thinking about artificial intelligence or blockchain or whatnot, into what this technology is putting, how is it putting to you, how is it being put to good use, and what's the problem it's trying to solve. So all of a sudden, instead of thinking about technology as a gadget or as a nice to have, even in life sciences, right? If you want to talk to physicians, or if you want to create some sort of dialogue between physicians, etc., you can't do this in person anymore. So it's not anymore, an option to go virtual just because it's cool. You have to do it because it's the only way. So I think that shift from just thinking about the technology first into it, solving a specific problem is where it created that greater adoption and scalability. In life sciences, again, different companies are on different ends of the spectrum in terms of adoption and wanting to be at the forefront of the digital and data, adoption. But I think this pandemic created the executive sponsorship very high up in companies to say, we need to do this, and it becomes a must. So this is from our perspective, I would say.
Yeah, I think that's it's kind of continuing on an existing trajectory. I think the real question that comes from this, this discussion is, will we be able to harness that, and will it continue? So, I think this goes to the points both that, Richard's made, Toby has, and Sophie are kind of the continuing journey here. Do we think that COVID-19 will pave the way for faster adoption of technologies in the future? And I think at this point, before we move on to our next topic, I'm going to ask our McDermott support to load up our first poll for our audience to give us their views on this. Mel, are you able to drive up the first poll? I'll leave a few minutes. We'll see if our speakers have persuaded our... Shall we wait a minute and then end polling, please, Mel? So we have a clear answer there. only 8% thinking we're going to stay the same. So I think a minority there, and highly likely, and yes, definitely, taking us to 80% of the answers. So I think that's very positive for health tech and just innovation generally. So moving from that, in terms of the question of how are we going to kind of harness this, I think I want to kind of ask the question of kind of what are the key issues about enabling this longer term adoption and accelerating new technologies into healthcare. I mean, for as long as I've been in healthcare, people have been talking about the need to adopt more quickly. And I'm afraid that is a long time, even if this webinar may give a flattering background to me. And I'm going to start with Andrew, if that's all right. You're the digital health lead, ABHI. I'm really interested in your perspectives here.
Yeah, sure. Yeah, it's a great question. Like yourself, being in healthcare a long time, and all that time been talking about how we can get certainly the NHS to adopt things faster. I think COVID is, one of the silver linings in COVID has been the way the NHS has been able to rapidly move and mobilize to adopt technologies, and not necessarily just new technologies, as Richard pointed out. Most of the shift in primary care wasn't to online consultation, that sort of thing. It was to a good old-fashioned phone. It was still a step up, should we say, from having to go to the GP office, sit in the waiting room, etc. How do we really embed some of those changes? There are some fundamental issues that we do need to overcome. Not least of those is funding for the system. The NHS has been underfunded in terms of its spend on technology, and this has been pointed out by the government's National Audit Office in a recent report, that we need to have long-term adequate funding to enable this. And what that funding needs to be used for really is to overcome a situation of, in some respects, don't start from here. We have a number of legacy IT systems that need to be revamped. We have a lot of existing commercial arrangements with technology suppliers that were signed in a different time, with a different set of circumstances. And really, as we move forward, interoperability is one of the key issues that we're going to see that needs to be addressed. And some of those legacy arrangements, both from the IT and commercial point of view, don't lend themselves to that interoperability. So those are some of the things that funding needs to be used for. We also have some specific issues within the NHS that, let's just say we have a very complex decision-making process in normal times. And that's the thing we've seen, washed away with COVID. Decisions were made, like the example given, the government's lead said, no, I'll take it on my authority to do something. Rapid decision-making, people taking the authority. What we must see to ensure that we do have this longer-term adoption and rapid adoption is we maintain a much more streamlined governance and decision-making framework. That's going to be one of the crucial things to really shift the NHS from being a 17-year period to get innovation to the bedside to weeks, months, perhaps a year at the most.
Yeah, and taking the more international perspective, I don't think these issues are just confined here to the UK. I hear my colleagues in other countries discussing very similar types of points. Sophie, do you want to jump in there, kind of add your thoughts?
Yes, happy to, and fully agree that, we've seen payers and regulators in multiple countries introduce a lot of flexibility for the adoption of telehealth, but also remote monitoring solutions, etc. I think what this creates is an opportunity to generate a body of evidence, also to make the case for these solutions moving forward. Because I think with the low levels of adoptions that we were seeing in the past, it was difficult to show that they work. and that they actually bring, a positive impact on clinical outcomes or in terms of efficiencies, etc. So there's a unique opportunity here for digital health companies, big tech companies, ourselves, life sciences, to come together and really generate the evidence that is needed to make the case for a sustained use of these solutions moving forward.
Yeah, I mean, you make an excellent point there, because of course the regulatory authorities across Europe, that's the MHRA in the UK and the other regulatory authorities across Europe, issued some extremely helpful guidance. I mean, we clearly had that with respect to ventilators, but there was other guidance, particularly around the fast tracking of medicines, medical devices. I mean, clearly there's been an impact on the life sciences industry so far as some medicines are occurred if they're not corona or COVID related. But I think the examples that have been set about how certain technologies could be fast tracked has been helpful. It's an excellent point. Toby, do you have a thought on that? Things that we need to do or could be done that pave the way, the key issues here to enable it to happen again?
Quite a lot.
Good.
I think what concerns me is that we might be working with a limited window, in that whilst COVID is still around, before it's vaccinated, have we got this this opportunity to really push an agenda to sort of bring the healthcare systems forward quite dramatically with digitization? I just have a slight feeling in the back of my mind that sort of once this passes, are we going to revert to our old ways a little bit too quickly? So I think certainly from our side, we're trying to, I think, capitalize upon the opportunity that we have now to help people solve a problem right now. And then I also wonder from the sort of the patient voice as well, is that I think we're going to have more waiting times, bigger backlogs, and people have seen what's possible now, the quality of life they can enjoy by potentially being managed for their health condition outside of hospital. And I do wonder if there's an opportunity for them to stand up and say, actually, we want this as a standard of care. Yes, there's always a place for human interaction and coming into it, but I think there could be something around the patient voice being heard. The biggest piece that we've found for long-term adoption, I think, comes down to how many stakeholders you have to engage with to adopt. And this goes for any country. I think the NHS is always a great example because it feels like there's always more. But one of the challenges we have is that, I mean, when you look across the healthcare system and you've got maybe 200 commissioning groups in the UK alone, we talk about the NHS being a single employer, a single entity, but it's far from it. And no matter what country you go to, the more people you engage with, the less appetite there is for innovative young companies, which is often where the digital innovation is coming from, to actually engage with the healthcare system. And so the benefits we've seen have been around sort of centralization of funding. I think integrated care systems who can see the whole care pathway and they can see where they can actually appropriate resources. And it's not having siloed budgets that we often have to deal with in many different healthcare systems around the world.
Yeah, I mean, that raises some very big questions about the opportunities around kind of a more centralized commissioning function, which I know is an extremely political question, particularly in the UK. And it's not, but of course, the politics of that are not confined to the UK either. Where you have a system that's separate or kind of where decision making is, we have these issues in any country. Richard, anything to add on those? I mean, there's a lot to talk about here. We've got incentives, got questions about data. Your good point there about data on Zoom and needing the data. Any thoughts to?
Yeah, John, I think I'll just really pick up on Toby's last point there. We're at a fundamental change in the way we're delivering healthcare in our country with a move to integrated care systems. So we flirted with the market from the early 90s on to improve healthcare. We put in an internal market. We separated our purchasers from our providers, things that have been done in other countries. The move now is back the way we think we can improve efficiencies through that integration of systems. Now, one thing that's definitely happened during this is that systems have been forced to work together. So if we look in the city where I'm based, our hospitals, instead of being competing freestanding organisations, we as a specialist hospital gave our facilities over to the system to allow the big hospital in the city to focus on COVID, and we picked up a lot of trauma. So that's forced that in there. And also, it's interesting, Simon Stevens at the weekend, and I made the point before about social care, said that he really wanted to sort out the social care issue we have in our country. So if you could now start, that's recognised as a weak point. One of the real problems which was locking our hospital system up before this was the fact we had there's 140,000 beds in the NHS. There's 400,000 in the social care sector. That social care sector does not have the capability to capacity to manage their patient group, which is mostly frail elderly in those beds. So they're coming into the service unnecessarily. Once they're in the service, it's hard to discharge them back to a system that has failed them already. So I think you'll start to see that bigger integration there. Hopefully this will fast forward it. The other thing in there is mental health. I think I've certainly had conversations with virtually exclusively male friends in recent weeks that have all volunteered the fact that unsolicited, that they're having days when they're feeling incredibly low and vulnerable. And I think the whole issue, people are realising how fragile our mental health is. And we've talked for a long time about this parity of esteem between physical and mental health. So I think that's another boundary that's being broken down. When you start getting into mental health and looking at a system, so you've got a sort of per capita funded system looking after a city or a city region. If you look at mental health, then 40% of the workload of the police within that area is probably dealing with mental health, because mental health isn't funded properly. So all of a sudden now you start to take a whole systems approach, looking at some of the wider determinants of both physical and mental health, and you start being able to move some of that money around. So hospitals now during this have changed the way they've been funded. We've moved away from a fee for service, a tariff base. We've now got a block contract. That's given hospitals some stability in their income whilst the case mix has changed. But certainly we think that's going to be extended to the end of the year. Certainly in Birmingham, we don't think we're ever going to see a tariff system again. So there are pros and cons with a block contract approach. But what it should do is break down some of those barriers between organisations that has been discussed already. So you haven't got this perverse incentive where you make an investment in one part of the system, say in the acute sector, but the benefits are realised in the community and there's no financial links between the two. So I think it's come at a time when we were moving to a different model of care in our country, and hopefully it'll expedite it, break down some of those barriers, and it will make it easier. We've been saying this for a long time in healthcare, but it should make it easier to bring in technologies that have whole systems benefits that otherwise may not have been recognised by the people who had to make the investment in them.
And so just on that now, we've had a very interesting question from one of our attendees. How can medtech digital health providers, in our case femtech for fertility treatments at Apricity, work together with the NHS to improve the patient experience, drive efficiencies, and overall improve the outcomes for patients? And that, in this case, pregnancy and birth rates, leveraging artificial intelligence projects. And that's a big question there. I think it really goes to the kind of the how do you work with the NHS? I don't know, Andrew or Richard, do you want to give some, maybe Andrew, a perspective there about how best to harness, where you've got a company with excellent technology? How is that engagement?
I'll give it a first shot. As I say, it's a big question. So I think it's probably to Toby's point, there isn't an NHS to work with. There's lots of bits of the NHS. And to a certain extent, it talks to your point about centralised commissioning. I really don't see that working for many digital interventions, because they're really, the key idea for me behind digital interventions is they help disrupt and enable patient pathways. And to that extent, they're very much a locally driven need there. So it's really about working with local organisations. There's no problem, Andrew. So just saying sorry for the difficult question. It's about working with those local organisations to see what is their situation and bringing the solution to them. one thing I would say is there's a few things to consider when working in the NHS. One is the evidence. What is your evidence? You do need robust evidence. And sorry, I don't know the background of you, Andrew, or your company, but yeah, if you're coming from a med tech background, you're kind of aware of the evidence requirements of the NHS. If you're coming from a tech background, you might look at things slightly differently. So look at what the evidence requirements are, and NICE have done a lot of, NICE, which is our National Health Technology Assessment body, done a lot of work around this. But also what the NHS doesn't want is a point solution. They don't just want something that fixes something at one point in the patient pathway, because that doesn't help. What they want is really something integrated into the pathway. A point solution just sort of recreates the problem in a digital format. So think about everything along the pathway and how the patient journey can be enhanced and how the system efficiency can be improved. If you can go to an NHS organisation with the evidence of that, with those improvements of patient outcomes, you should get a hearing.
And Andrew, apologies if I'm asking a difficult question, the kind of concept of a single front door through the NICE appraisals and some of the digital health kind of projects, do you think that's helpful? Do you think that's a good way for manufacturers and kind of providers of technology to access the system? Appreciate you may not answer.
No, I'll certainly answer. I might disagree with Richard, who knows? I don't think there's ever going to be a single front door to the NHS. It's too big and too complex an organisation. So really what we want is good, clear signposting to the ways in. There could be a number of front doors, as long as we have clear signposting of when to go to which door, I think is the key thing, rather than trying to push everything through one portal. NICE has limited capacity. Yeah, there's no way that every single technology can go via NICE. It's just not feasible. So it's really about finding the right approach. It could be through NICE, it could be via the AHSNs, it could be direct to integrated care systems. It could be something that is nationally commissioned. It really depends on the offer of a particular company.
Yeah, I mean, that's I mean, it's a long and complicated issue, isn't this, and oft discussed. Richard, in your view, the kind of the steps that providers should take, or manufacturers should take of technologies to kind of encourage that take up, to speed adoption?
Yeah, well, I agree with Andrew, actually. I mean, it depends is the answer to actually a lot of questions about the NHS. It is a case of finding the right vehicle. Andrew asked the question, should come and speak to us. I mean, my Andrew's answered as pointing to things like the AHSNs and possibly national programmes. ABHI, we have regional, we have MOUs signed with 6 city regions at the moment, and it's a coalition of willing people that want to get that hearing. It's about trying to get it to the right place, and that's what organisations like ours are here to try and do. Try and save you some of the legwork and land you in the right place. But no, well, I think Andrew covered it pretty well, actually.
And Sophie, do you have anything to contribute to this kind of point? I mean, interesting perspective from your side.
I think, Sharon, what we started doing recently in life sciences is actually going together with some of these digital health companies to reimbursement bodies and say, we're teaming up, we can see the benefit, coming back to the point on evidence that Andrew made, right, to bring that to the table in the discussion. So I think there is, and I fully agree, by the way, about the solution not being a point solution, and increasingly you will see also life sciences companies moving away from solutions that they want to tag to their brands, but rather, something that will benefit the pathway overall, because otherwise you will really struggle with adoption. So we're seeing instances of, life sciences companies teaming up with digital health companies, going to the reimbursement bodies together and see how we can contribute to building that body of evidence together.
So moving a little bit further on to, this is a part of our wider summer series for investors and private equity. the audience here is international and has a wide range of investors and manufacturers. And the key questions, I guess, that when you're embarking on new investments in this space, what is it that investors should be looking for when they are approached for funding, when they're looking at new technologies? There are a whole range of issues, and I will finish our discussion in a little bit with a poll. But just before we start, I'd be kind of grateful for kind of perspectives on this. And I'm happy for a volunteer first, otherwise I'll might pick on Toby if he'd like to.
I'm happy to take that. It's interestingly, actually, it goes. I think Andrew, you used the word disruption. I'm terrified of disruption when taking stuff to the healthcare service because it's a quick way to get them to close the door, I've found. And just in terms of like investing in a company that's looking at integrating with the healthcare system, it's, I think, very important, obviously, to recognize that you're often dealing with a lot of different stakeholders. And understanding that the company has to have understood every single point of the pathway, and that I think, to Sophie and Andrew's point, that if you just do one intervention, you haven't considered the entire journey, say that patient goes on or the healthcare system goes on dealing with that patient, you may completely miss the fact that there is a glaringly obvious reason why technology shouldn't be adopted. I used to work with a very good consultant who spent his life telling people that their ideas wouldn't work because his whole job was to map out whole care pathways, and he did a brilliant job of recognizing that. Really sort of, I think, understanding, making sure that people have understood where the value lies in their innovation, having it sort of, applicable more than to one area of healthcare is often very advantageous. Now, of course, there are companies that specialize in single markets, but I think certainly in this space of digital innovation, I think there has to be a consideration for the global implication of what you have developed. It's not just talking to the NHS, it's not just looking at sort of the US healthcare system. And I guess tying into that is, again, evidence. This is an industry that actually does like its evidence for it. All that being said, if you can find yourself a nice partner who can circumnavigate all of that, pay for your innovation and give it to healthcare for free, well, all the better, really. You still have to consider the pathways you go through, but there's we are finding there's some very interesting synergies with large multinationals that are very interested in this space and how they can leverage their own solutions off the back of digital innovations. Yeah,
I think that definitely reflects our experience at McDermott. Increasingly multinationals working in this space. Sophie, do you have, what are your thoughts here?
Yes, sure. I think the way I would look at this, and maybe at the risk of oversimplifying, but really looking at solutions that strike as triple win. The first one, first and foremost, I mean, we're all in this business for patients. So something that will, or evidence that shows that clinical outcomes for patients are being improved is number one. So this is the first wheel, if you will. The second one, which we also, found a bit of resistance in the past from physicians. So you want the tool to be easy for physicians to use. A lot of times we see solutions that generate a lot of data, but then the physician is just completely overwhelmed with the data and doesn't really know what to do with it. So you need it to be fit for purpose in the clinical workflow as well, and something that is easy and intuitive for physicians to use that will help them serve their patients in a better way. The third one is around payers and public health authorities or insurance companies, etc. There is an element, in a lot of digital health solutions that are succeeding currently, is that they show that they can, by improving clinical outcomes for patients, keep patients away from the system for longer. And we've seen hospitals being, again, completely overwhelmed in the pandemic and even before that. And the losses that hospitals in the US are taking are really, telling of the situation. So if you manage to find the solution that serves these three purposes, I feel is where you find, that at least the openness to discuss becomes higher.
Yeah, that's the triple aim here then. Richard, Andrew, what your thoughts? Perhaps Richard, if you you must have seen so many technologies. What is it that investors are looking at? What would give them concern is another.
Well, no, I try and look at this positively in terms of, I mean, there's always a laser focus on operational efficiency, but I think that's kind of writ large now. If you've got a technology in cancer or cardiac, diabetes or obesity, we're going to be talking about this for years. Long after we're gone, there'll be people on these, whatever the next iteration this will be, talking about diabetes and cancer and all. I've always worried about what happens if your super innovation is in something like urology or ENT. I think there's such a focus on operational efficiency now. So we talked before about capacity. Well, I think the service is struggling to see how it can get back to more than 60-65% of capacity. So if you look at my hospital, we've lost 20% on social distancing, 20% of bed capacity gone. We've got donning and doffing of PPE for our staff in theatres. That takes time. You've got enhanced infection prevention measures, so you need longer downtime between cases to clear the air in theatres. We're asking a lot of patients, they're having to self-isolate, so that capacity is down. So people have got a real focus on operational efficiency, and that brings a whole raft of technologies in that I think you can sell in a different way. It might be back office stuff, organising stuff. It may be stuff that enhances discharge. We can get throughput quicker. It could be the more kind of hands-on infection prevention measure, all that kind of stuff. So anything that can increase operational efficiency, I think, and help throughput of cases will be a real interest, a sort of renewed interest, I think, to the operational bit of the service.
And Richard, on that, do you think that there is, having been through what is an exhausting time for everyone? I mean, I think it's been exhausting for even those of us who are just kind of working remotely. Do you think that there's going to be appetite and capacity to kind of manage new technologies at a time when people are going to be recovering from a time of extreme hard work? And how do you think that is tackled?
Well, I think so, and then we'll have to. I mean, we'll have no choice but to do some of this. And remember, a good chunk of our workforce is not exhausted. There's a lot of frustration in the service. Clinicians that have been sat on their hands really have not been able to get on with the routine work. So there's very different. I mean, the fact that we have got a lot of frontline staff are exhausted, and actually in our hospital, the people we're most worried about are the suits. The executive directors who don't think they ought to be seen to be away from the trust at the moment. But actually, we need them up and firing as and when the elective has an uptick. So no, I think there will be an appetite for that, and there's a lot of clinical staff that have not done a lot of work, particularly our consultant surgeons.
And Andrew, what your views on this? What are investors looking at?
I think for me, there's sort of two interlinked things. It's about scalability and transferability. So for any given technology, what is the ability of that technology to scale up, both from the technical point of view and from the business model point of view? And from that business model point of view, is it transferable between markets? So it's basically only the US market that can stand alone and sustain a company. If you're domiciled in any other country, you're really going to have to export and put your solutions into other health systems. So is it a model that can work in a socialized system, an insurance system, a commercial system? So does that business model transfer? And from the technical point of view, can you scale up? Can you bring on more patients on the platform, or expand the cohorts, etc.? And on both of those, are you using open international standards that will allow the interoperability of data from different systems and allow the interface with different EHR systems, etc., in different countries? So they're the two big things for me.
Yeah, so interoperability and scalability, is that, if I've got those right, the use of data, and we discussed this at the beginning about kind of the ability to use data to and it's kind of been a theme throughout this discussion, the need to be able to evidence that technology works, it is effective and improves outcomes. Some of the things that we see are concerns about being able to demonstrate that, concerns that hurdles around data, kind of regulatory issues, research and investigations takes time. Do you see that as something that is manageable for investors?
It's manageable, but yes, data is. There's so many analogies. Is it oil? Is it the lifeblood? Whatever. Data is fundamental to how we take forward digital health technologies, but how we take forward the health systems generally. If you haven't got robust, high quality, well curated data sets, you can't really deliver well functioning health systems and digital technologies. And for me, there's a few things in there. First of all, I think Toby picked up on it, but it's worth emphasizing is it's about patients and the trust of patients in the health system and in particular technologies to allow their data to be used. That's really the starting point, and then it's down to the governance within the health systems on how they share that data. And some of the words you use about investigations, research, etc. We talk a lot about data for research, but actually the use of data is far wider than that. It's about research and getting those insights to develop your technology. Then it's getting the data to train the algorithm, to do your validation and verification, the data to prove that the implementation worked, to do the cost modeling, to look at the outcomes, to feed back that loop, into redesign and iteration. It's way more than just research. So it's about collecting data, along the patient pathway and across the lifetime and use of the technology. So
and one of the interesting things that has come up, I think, is a kind of wider discussion is whether the pandemic will lead to a greater understanding of the need for that information. So kind of almost a donation by citizens and patients, the importance that their own information has to contributing to new technology. I mean, it's something that I think when we've been in any country watching Corona and COVID figures, it's clear to anyone who watches that our data is being collected and it's for the benefit of the delivery of health, the improvement of health. As a question for me about whether ultimately that's going to have led to a better acceptance that this is what it's for improving outcomes overall. Sophie, do you have thoughts on whether that's going to be we're going to be into an environment where there's a greater understanding of the need for that sharing?
Yeah, so I think it certainly reopened the debate on data privacy with the contact tracing technology and the different models, centralized, decentralized, etc., that were put forward. It did reopen the debate. I think there is no clear cut yet as to whether the broader population and individuals will be very open to sharing their data. The other thing that we're seeing, Sharon, I think is a nuanced view depending on who that tech provider is. So there is trust in the system and in public health authorities as one, but there's also trust in variable degrees in big tech players who are coming into the picture. So think of your Microsoft as one of the most trusted brands. And then, if you look at some of the recent stats, Facebook looking a little bit less, at the forefront of people's trust. So there will be nuances in terms of the acceptance, depending on who is using that data, what type of model, and to what purpose. But it did open the debate for sure.
Yeah. Richard, do you have anything? I've got a question here, but before I go on to that, do you have anything further on that that you'd like to mention?
Yeah, so to answer your question, I hope so. I mean, one of our when we were at our manifesto ahead of the last general election, we had one of our recommendations was a public awareness campaign to stress to people the value to them of Andrew's smiling because it was his idea actually, to stress the value to themselves of being willing to share data. So I think we've probably all been guilty of getting really excited, particularly about the NHS, of these. We've invested in digital innovation hubs now. We've got the largest single payer health and care system in the world. Everyone thinks we've got all this data and we can use it for research. Well, actually, the message I think to people is, you know what? Sharing your information improves your care almost immediately, particularly when you're talking about technologies based on AI and deep learning, so that improve with every piece of information that goes into them. It's going to help us help better. So I hope everyone's right that people are now looking at the value of sharing data, and we'll see less. I've always thought we've been a bit squeamish about sharing data. I mean, Tesco's knows more about, Walmart, if Walmart knows more about us than the NHS, and people are very happy to share their data with something. And it is a bit of a paradox. Sophie's point's a really interesting one. We did some work on this a while ago. People do seem to be reluctant to give their data to the state, actually. So there is a conversation that needs to happen.
Yeah, so we've had a question here, which I think I'm going to just, I'll leave our panelists a chance to read that, but I'm going to tackle it in the first instance, and then we can have a little discussion about it. And it's a question about whether or not payers are prepared to pay a premium for use of technology that has an evidence base for improving outcomes and delivering efficiency, or does that efficiency ultimately drive the price down for that technology? Now, clearly that is a question that, apart from anything else, the payer needs to recognize the investment that has been placed along the way, that a technology that arrives ready for sale or ready for adoption has already had significant capital investment behind it. But there are two things here that I'd kind of make an observation on. At the beginning of the year, there was a proposal which was interesting about who bears the cost of new technologies, whether this will ultimately come through, because I'm sure we're going to see some changes in our payment system anyway, but a question about where the benefit lies for new technologies. And ultimately, I think one question that we would often discuss with investors is who is the purchaser for who reaps the benefit for this technology? And the technology tariff proposed two options. The one was where the benefit was for a wider, more efficient system, or for benefit on a public health basis, and that would go to the payer to pay for. Whereas if the efficiency was on a pathway, so making a pathway more efficient, where the provider would be paid, that may be a technology that was purchased by a provider of healthcare. And that really kind of is a kind of key question of who are you selling to? And of course, some of this, of course, Sophie and others the purchaser may of course be a pharma company or life sciences company wishing to demonstrate the efficacy and outcomes of particular pharmaceutical products. So I'm just allowing that as a little bit of a preamble before anyone else would like to jump in and answer that question.
Yeah, certainly I'm happy to give a view. I guess, yes, health systems are prepared to pay more for something that delivers more. The quid pro quo for that is the more of the price premium you're asking for because of the greater benefits you're offering, the more robust and extensive your evidence will need to be. So it's a bit of a trade-off in terms of, do you want to invest in that evidence base to prove that point, or do you want to kind of go with a slightly lower price? It's kind of a sliding scale there, but yes, it's possible. And the NICE methodology again in the UK is kind of based on that approach. It recognizes that you pay more for more benefits.
Sophie, did you want to say?
Yes, you can see it on my face. The one thing I wanted to add is we're seeing also in the US, for example, a consolidation between payers and providers, the CVSs and Aetnas of the world, etc. I think this will create a more alignment in the incentives in this as well, right? Because where typically before, you know, the provider is paid by the procedure and the payer wants to save on the population that they're responsible for, now you're seeing these two come together. So there will be also an element of this consolidation that will play in favor of some of the offerings that we're discussing.
I think this is, unless anyone has anything to contribute to that question, I'm going to ask our sport team to run up the next poll. So this is a poll asking what are the key issues for investors, and you are able to select one of those. So if we could start the polling. Wait a little bit for the so if we share the results. So we have a clear answer here, a clear path to reimbursement, which I think probably not unexpected answer, but it really does go to kind of the core of that. If you're investing in new technology, it really does need to be understood who both the purchaser is and the method for that reimbursement. Just before we kind of close, does anyone have any final thoughts on the poll? Are we disappointed that unmet need for new technology and clinician ease of use featured poorly in that?
This is an investor audience, Sharon. These are investors, yeah? You've got to buy, you've got to sell the stuff.
Yeah, but I agree, but also if you're not able to make the case for it to the payer or whoever will give reimbursement by proving the unmet need, proving that it works, etc., it's not going to fly. So I think the audience, yes, they're investors, and for sure path to reimbursement is very important. Unless you can make the case for all of the above, you're not going to get the path to reimbursement. So I think I'm happy with the answer.
I agree entirely. Toby, Andrew, Richard, any final thoughts here?
No, I just think I'd be positive. I mean, we talked about some of the positives, some of the learning. The UK is at a really interesting inflection point, anyway, isn't it? We're thinking differently about regulation. We're thinking differently about how we're going to introduce technologies into the NHS. We have a life sciences strategy. We have a bill going through our Parliament at the moment, which is the Medicines and Medical Devices Bill, which is about giving essentially about giving the regulators the power it needs to do what it needs to do. But there are two tests in that of any future regulation. Don't bother reading the bill. There's nothing in it. It's an enabler bill. It's a Brexit bill. All the fun's going to come further down the line in secondary legislation. But there are two key tests of those future regulations which are enshrined in the bill. One is patient safety. The other is to make the UK an attractive place to develop and distribute medicines and medical devices. So I think we've talked about this for a long time in the UK. Things are conspiring to come together where we really should be able to deliver on some of the things that we've always talked about, but what we do have to offer.
So on that, we're just at time, and I wanted to thank you all so much for contributing to a really excellent discussion. Really value, I know how busy all of you are. The webinar has been recorded. We will be distributing it on our social media platforms and sending it through to you. This has been a fantastic discussion. It's part of a series, and we have another 2 webinars as part of this Investor Health Private Equity Europe Summer Series, one coming up, which is in relation to government and regulatory risk, and then another one on key deals for transactions. And anyone attending is, of course, welcome to dial into those too. And so with that, thank you very much, and thank you to our audience and panelists.